before they do anything.
All right, so finally, Dr. Seth is going to talk about a little bit more advanced disease and some of the newer therapies that have really come on board just the last few years.
Hi guys, hope everybody's doing well tonight. It's good to see everybody. I know I don't need this, so I'm just going to talk. So my talk really is about immunotherapy. I know you guys have seen a lot of TV commercials, Novolibimab, Opdivo, you've seen the Keytruda, the Merck trials. These are all therapies now that are indicated now for advanced stage lung cancer. And pretty much what do I mean by advanced stage lung cancer? We're talking about patients that are typically at stage 4, where surgery is not going to be involved, or possibly radiation is not involved, okay? Okay. First, I'm just going to talk about a brief overview of the lung cancer situation. In this country, lung cancer, as you know, is still one of the major problems we have here. In the new case in 2017, they estimate almost, 250,000 people, globally 1.8 million. 2017, the deaths, they're estimating to be 155,000, 1.6 million globally. And 80 to 85% of cases, as we've talked about, are non-small cell lung cancer. So what does that mean? Typically, lung cancer is broken down into 2 cancers. One is small cell lung cancer, and one is non-small cell lung cancer. Small cell lung cancer is treated completely differently from non-small cell lung cancer. So I'm going to focus this talk on just the non-small cell lung cancers, okay? If you have questions about small cell, we can talk about that after the talk, okay? About almost 60% of patients at the time of diagnosis of their lung cancer are going to be stage 4. So that's why this talk is kind of relevant to those patients, and that's quite a bit. And don't forget, the standard of care for a stage 4 non-small cell lung cancer, it is chemotherapy. Okay, so this is a nice diagram here. We're going to talk about what do we used to use. Now, stage 4 lung cancer, typically, as you guys all know, chemotherapy comes to mind. What is chemotherapy? Chemotherapy are drugs that were invented that stop cells from producing, okay? Stop cells from proliferating, from growing. And those are the old types of chemotherapies. Then what happened? Around 3 years ago, we realized certain lung cancers, if we test their pathology and look for mutations, meaning proteins that are screwed up in the tissue, such as epithelial growth factor receptor, ALK, ROS1. These are the medications where there are pills which we can offer patients, okay? Tarceva goes against the EGFR mutation. ALK1 and ROS1, we have crizotinib, okay? So a lot of times when we have advanced patients that have stage 4 lung cancer and they have these mutations, we can offer them a pill form of chemotherapy, okay? Now recently in 2006, we've realized the immune system works in lung cancer, and they're targeted. And here in the diagram it says anti-PD-1, anti-PD-L1, and CTL4. These are programmed cell death receptors, okay? These are the checkpoints for the immune system, of where cancer is able to kind of hide itself, so the body doesn't recognize you have something growing inside of you that shouldn't be growing inside of you, okay? So here's a little diagram basically of the immune system. What this is showing is basically, well, this is a cancer cell. How do I get my immune system to attack it? Okay, typically cancer, sometimes what they do is they do a cytotoxic receptor here that activates a dendritic cell. A dendritic cell is what? A dendritic cell is one of the cells that we have in our immune system that recognizes when we are sick, like when we have the flu or when we have a pneumonia. It's the antibodies that generate, that attack that infection. So what happens is these antibodies get turned on, and what it does, it makes these cells not recognize that there's a cancer cell on there. So we made a drug to block that, and that is ipilimumab. And this drug did not work so well in lung cancer, but it works in melanoma. So what happens now? So we went and we did another checkpoint. We found these programmed cell death antibodies, Novolibimab and Pembrolizumab. These are the ones you guys see on TV, Opdivo, Keytruda from Merck. And what they're doing is they're showing basically how a cancer cell will come and block this T cell from activating. When the T cell gets blocked, it doesn't recognize the cancer cells. So what these drugs do is that it stops the cancer cells from fooling the immune system, basically. And so then what happens is that our immune system then activates and recognizes the cancer cells. And that's how these drugs are working, okay? All right. So these, I'm gonna go through a few slides. What are the clinical applications for the immunotherapy for advanced non-small cell lung cancer? Now this is a study. What do we do as an oncologist? I basically give chemotherapy drugs to patients. How do I do that? I base it on studies, okay? This is a study that was presented in the New England Journal of Medicine. As you know, that's one of the best journals of medicine around here. They did a study in 2002 where they took a whole bunch of chemotherapies, different drugs, and they said, okay, how does it work in advanced small cell lung cancer? Okay, patients, you can see, they pretty much started off at 100% overall survival. They give the chemotherapy drugs, and we see eventually over time patients will succumb to their death, okay? Which one worked better than the other one? They all worked pretty well, almost exactly the same, as you can see by the graph. And this pretty much lasted up until 2015, pretty much the dogma of what we were given. All right, so now, as I said to you before, how do we go by and realize that these drugs actually work for patients? We do studies, and basically this is one of the best studies that came out when they first looked at pembrolizumab versus chemotherapy as a first-line therapy for advanced small cell lung cancer. And basically they took patients, they randomized them to 200 milligrams versus chemotherapy. They looked at patients, basically, if they had the mutations. Remember how we talked about the EGFR mutation, the tyrosine kinase mutations? They were not included in the study. And basically they started giving these drugs. This one is given once every 3 weeks, where chemotherapy is given. And this was also presented in the New England Journal of Medicine. And basically this drug showed the same thing for a lot of patients. Overall survival for patients who got the immunotherapy drug lived about 10.3 months on average. Patients who got chemotherapy alone, they lived only about 6 months, okay? And then you have immediate overall survival. You know, they're not even, as you can see here on the immunotherapy drugs, the orange line, patients continue to live. So that's why this got this study excited, because they realized that if you give the immunotherapy drugs versus chemotherapy, the immunodrugs work better. They were living longer. Okay. This is the other drug that came out, nivolumab. This is Opdivo, where you've seen it on commercials. They did the same thing that they did with the other drug. They looked at patients with advanced non-small cell lung cancer. And what did they find again? Sorry, this goes back to testing. That these patients lived longer as well. So they went ahead and they tested it again against docetaxel, which is one of the common chemotherapies that we give. And they wanted to see if this drug would work. And they were looking at pretty much, as I said to you before, in non-small cell lung cancer versus small cell lung cancer. Non-small cell lung cancer, they're squamous cell versus adenocarcinoma. And they looked at those kind of subsets of pathology. And believe it or not, the immunotherapy drugs won out again. So the immunotherapy drugs was beating docetaxel. You can see here, this one on a squamous cell cancer, the overall survival, patients beating overall survival 9.2 versus the Taxotere was 6 months. Same thing, you had the Opdivo beating the non-squamous cell overall survival was 12.2 months, almost a year. So patients who were getting the immunotherapy lived about over a year versus Taxotere, they only lived about 9.5 months. So again, this study indicates to us that the immunotherapy drugs are here to stay. It does work for advanced non-small cell lung cancer. And again, this is another slide which I'm presenting here today because remember how I talked to you guys when we do pathology testing on these things, we look for mutations. There's something called the PD-L1 stain, and that's now indicated to do for advanced non-small cell lung cancers. And this drug kind of shows you that patients who have a positive PD-L1 stain do better, okay, over patients that don't have it. But patients that don't have it still responded to the immunotherapy drugs. So it shows that the stain is not 100% accurate, okay? All right, and this talks about how well they did with the expression. If they had more expression of the PD-L1 on their pathology, which is the tissue of lung cancer, they did better. All right, and this drug, again, this one is looked at Keytruda, where they tested it for Taxotere versus the pembrolizumab at a higher concentration versus 2 milligrams per kilogram. And what did they find? Overall, this is again published in another journal, but you can see here, patients who got a higher concentration of immunotherapy did much better than patients who got a 2 milligram, a lower dose concentration, then again versus chemotherapy, Taxotere. So you can see the immunotherapy, you can see these slides that are presented here, the immunotherapy drugs over conventional chemotherapy is beating the odds. You're living longer, you're having overall survival benefit, and your median survival is also increased. And this is another study that done it with the, looking at again with the percentages of the ligand, how much was expressed, and you can see again, patients who got the higher concentration live longer. Okay, this is a new drug that came out recently, and that's why I'm presenting this one, because this drug actually seems to work even better than the other immunotherapy drugs, but is indicated for second line, and that is adazolamide. This was the OAK trial that's come out, and this was published in 2016 in Lancet, another article, and you can see here, it's beating chemotherapy again. The lines are separated, they're not crossing, and this is what motivates us as oncologists. What drugs do we use? What do we offer patients that present to us when they have a stage 4 lung cancer? All right, now I've talked about basically the immunotherapy drugs, and I've shown you the data. This is why we use the immunotherapy drugs. Are the drugs without any risks? They have risk, and we're going to talk about them for a minute. These are the side effects of the immunotherapy drugs. So if you think about it, the immunotherapy drugs, what do? They activate your immune system to attack your cancer cells. There is a risk still that the immune system will attack your own body, and that's usually what happens. So this is a lot, but this is what can happen. It's all the itises, basically, okay? You can have pneumonitis, which is when your lungs get inflamed. You can have thyroiditis, where your thyroid gets inflamed and patients will get a big goiter and their neck will swell up. You can have uveitis or iritis, where your eyes get infected or with antibodies that are attacking it. The skin is a big problem too. They'll have skin rashes out of the blue. Why did this happen to us? Because your immune system is attacking your skin. It's attacking your own body. The biggest one is the liver, hepatitis. All right, you're not getting hepatitis because of an infection or a viral infection. You're getting it because your immune system is attacking your own liver. Colitis, and those are the patients that get infections in the colon, and that causes you diarrhea and abdominal pain. The kidney is also a big thing too, where the kidney function starts going down. Why? Because you have nephritis. Basically, you won't have abdominal pain or like a urinary tract infection, but your kidneys, they could potentially fail. So that's renal failure issues that we worry about. So not everybody gets this. I've given a lot of this out there, but people do get it, and it's a real concern, okay? So what do we do for that? We have to be vigilant. We have to keep an eye on it. I have a lot of patients that I make them sign actually chemotherapy consents, because the drugs are not just easy. They sound great. They sound like they work, but there are side effects of the drugs that we give, okay? So you can see most of the patients, though, as I said to you before, they can get it at any time. So you can see here, this diagram shows even 2 years, a year or 2 years, you can still get infections, and they can have pneumonitis or you can have colitis. Usually within the first 3 months here, this diagram shows you that the skin is the biggest thing we worry about. Next is the colitis, which is diarrhea. And then you have the pneumonitis from the pulmonary issues, endocrinology stuff, which is the thyroid issues. You get this drug and patients will come in the next day and the neck is swollen. It's their thyroid, okay? It's just big because the drug is... Necessarily, that's also sometimes a good thing, because that means the drug is actually working. You know what I'm saying? It's making the immune system work. So we have all these things that we worry about. So basically, this is something that I want to point out to you guys, because the drugs do have side effects that we have to worry about. So as I said to you, one of the biggest problems is the immune-mediated pneumonitis. Most patients with advanced lung cancer, they have a smoking history. They either have emphysema or COPD, right? Those patients tend to have a higher risk for developing the pneumonitis. I don't know why, but they just tend, most likely because their lungs are already damaged already, and therefore the immune system takes there. So as I said to you before, patients who have prior radiation to lungs and history of COPD, they're the ones that are higher risk for this stuff. Now, what is the signs and symptoms of pneumonitis? You can get a cough. You can have shortness of breath. You're using your oxygen or your compressor, they're walking around, they need to turn it up higher. Those are early signs of pneumonitis, okay? So what do we do for these patients? Sorry, before we get to that, this is a few pictures that I have done for you. This is what can happen in the rash. You can see here, it can be a localized rash on the forearm, or it can be the whole arm, the whole body. You see here on the bottom here. They can have severe or it can be mild, it doesn't matter. We always have to make sure there's nothing else going on. Patients typically don't have allergic reactions to the immune system, drugs that we're giving them, but this is one of the problems when they get the rash. We have to worry about that. And sometimes we do have to hold the drug off. So as I said to you, what do we do? The general principle of the immune-related stuff is we usually have to grade them. Basically, can we just support them through it, or do we have to stop it? So we have grades 1, 2, 3, and 4. If anybody gets a grade 3 and 4, meaning that it affects their life or it's life-threatening, we have to discontinue the drug. And you can see here, we always have to give steroids. And nobody loves steroids, but steroids work for a lot of patients. And patients with COPD are typically used to steroids, so we give more steroids at a concentration. Grade 2, we have to withhold the drug, considering reducing it if we have to for the toxicities. Then again, we still use steroids, okay? Grade 1, as I said to you before, we just do supportive care. We hold the drug and see if we can re-challenge you again. Okay. So finally, what is the direction? What does this mean for most of my patients? All I know is that somebody comes into the office and they have a stage 4, we have to offer them immunotherapy for their lung cancer. Why? Because we know it works, okay? So now the study is going to be like this. Are we going to use immunotherapy alone? No, we'll probably use immunotherapy with a combination of lung cancer. And I'm presenting this because this data is showing that most of the time when you come into the office now, right now, if you're stage 4, we're going to keep the immunotherapy drugs alone. But they're studying now the combination of the immunotherapy drugs with chemotherapy. And the reason is, well, why would you do that? Well, the reason is kind of here. This is a study that's been published already in Lancet. Basically, the combination of immunotherapy with chemotherapy has an overall response for all the patients, about 98%. Overall response, 55%. 98% have a decrease in their tumor burden. If you do chemotherapy alone, they only have a 29%. So taking 100 patients, and I give you the immunotherapy with the chemotherapy drugs, that means over 55 of those people will get some response in their tumor. If I just give you chemotherapy alone, only 29%. If I give you immunotherapy alone, it's only about 30%. So you can see here, the synergistic effect of giving immunotherapy with chemotherapy is a bit more powerful. So that is probably what's going to be happening next with the immunotherapy drugs that we have. And this is another one that showed the combination, the progression-free survival, but the overall survival is still slightly together. But you can see with the response rate, we hope that this will translate into overall survival for patients. And the treatment-related incidence of stuff is pretty much similar to the immunotherapy drugs alone. And these are a few slides where we're going to be talking about, is this here to stay? Yes, they're developing new and newer immunotherapy drugs. The Keytruda and the Opdivo drugs are pretty much the first generation. And you can see the second generation is like the cars come out and they're going to build up a new car. So the newer models are coming out for these drugs and they're going to be better probably than these drugs that we have here. And this just gives you an idea of how many studies are going on right now. This was in 2017, and these are all enrolling. And these are all trials that we're experiencing for patients for advanced non-small cell lung cancer. So in conclusion, basically, patients who have advanced lung cancer, if they have the PD-L1 expression on their tissue, we're going to offer them the immunotherapy. If they've had other chemotherapy and they progressed, we're going to offer them these drugs. As I talked to you about the azadolamide and novolumab and prabozolamab, we'll offer them. The PD-L1 expressions in the tumor does have a likelihood increase in response, but predictive availability of this biomarker is still debated. So even if you don't have the PD-L1 stain, we're still gonna offer you the immunotherapy drugs. These drugs are easy to give, but again, the side effects are a big concern for me, so we have to worry about them. And eventually, we're probably gonna be combining this with chemotherapy, and that will probably be the new standard of treating stage 4 lung cancer patients. Okay?
What is the cost of these drugs?
To the insurance companies or to you?
Well, a lot of people right now I'm worried about insurance at this point. And if it will be affordable, and coverage, and, I mean, we're looking at a very high cost, aren't we?
Yes.
Yes.
We're looking at a cost of about, I believe, $35,000 per infusion.
And how many infusions would you need in a regular course
So
of care?
so we'll talk about that. So when patients come in and they're advanced lung cancer and we're starting these drugs, if it keeps working, we'll keep giving it. There's no study right now to show when should we stop. To say give you 12 cycles or give you 16 cycles, we don't know that data yet. So most of the time with stage 4 lung cancer patients, we keep going with chemotherapy until they progress. And then we change the chemotherapy. Or until they experience a toxicity that they require a chemotherapy holiday or a break.
Now, given that the immune system is so individualistic,
Yes.
and this is so highly targeted to that,
Yep.
I mean, obviously we're going to improve and get better, but there's going to be a point where it is going to be so individualistic that it may be very difficult to control some of those symptoms.
Correct, and I've experienced that already. Some patients that I have on this stuff, we've had somebody now on it for a year, not a problem. We've had somebody on it for 4 times and they couldn't tolerate it.
So does the positive PD-L1 marker give you any indication of that?
No, and there's no litmus test to say to you, you're not gonna have a problem, but you'll have a
And
problem.
there's no one to even suggest that you might.
There's no test, and that's what a lot of people are looking for. All we do know is like the pneumonitis is a big deal because if they've had prior radiation or COPD, we do have to be more vigilant because we do know from data already, those patients get the pneumonitis, and that's the problem.
It's amazing how.
Yes.
But basically in oncology, we are gonna be coming to that. We're gonna be, doing almost like we're gonna give you, like, we'll take your tissue. You have lung cancer, we're gonna run it through a genomic sequencer, we're gonna find out all the targeted therapies that you can take for your lung cancer. We don't know, and that's pretty much what oncology is probably gonna be coming to, because
Very
already,
individualistic.
right, we'll look for the molecular targeted therapies for
Markers.
patients, like the EGFRs, and then we'll go by treatments for those. If you have the ALK gene, then you'll get a pill form. If you have EGFR, you'll get the Tarceva pill. If you don't, if you have a PD-L1 stain, we'll give you the immunotherapy drugs. So we're getting better at helping patients select what therapy is designed for them, which will give them the best response.
But it's also a lot more complicated than we ever thought 20 years ago, isn't it?
Oh, yeah.
It's going to be. For example, when I finished my fellowship in 2005, wow, that's a long time. 2005, our textbook was a 2-inch textbook, and it was printed. Now they can't even print the textbook anymore because it's online or on a CD disc because it's so much information. And now diseases are getting more specific. We're getting more detail for lung cancer. We're getting more detail for pancreatic, colon cancer, rectal cancer. We're getting more and more details for those tumors and how to specifically target therapies for patients. And hopefully give them the best bang for their buck, as we say. Minimal toxicities, best response.
So is all this treatment done if the cancer hasn't spread? Can it be stage 4 and not have spread?
Can it be so by definition, a stage 4 means typically when lung cancer has escaped the lung areas.
Oh, that's what I thought.
That's a stage 4.
Okay,
So if it's gone to the liver, to the bones,
right.
those are stage 4. Those are advanced.
So what stage are you still confined to the lung? Like second or stage 2?
There are stage 1, stage 2, stage 3. Those are usually typical tumors that are based on the size, based on lymph nodes within the chest. Stage 4 is, as I said to you before, are tumors that are from the lung, but they're outside of the lung, meaning to the liver or to the bone.
Right.
Any other questions? I hope that was informative. Thank you.
Westfall and his colleagues from upstate for coming tonight to give it. Very, very interesting. I found it very interesting.
Oh, it was.
Thank
It
you very
was.
much. And I want to thank all of you for coming. We greatly appreciate you coming out tonight.
Thanks, and I just want to say, you know, I finished my training a few years before Dr. Seth, but this is really the first time in, 30, 40 years that we've seen so much excitement, both in screening, but also treatment with radiation, surgery, and new drugs and immunotherapy. So things are really changing quite a bit for the better for patients with lung cancer. Thank you all for coming tonight.
Thank you.
Video that we've taken on our website, so if any of you have any follow-up questions,